Hi, Dr. Windisch from Sparks Pediatric and Adolescent Medicine. Welcome to our video series for students. Today we're going to talk about pneumonia. If you're a parent and you have questions, we're happy to see you here in our office, area code 775-359-7111. And please just be aware, if you're a parent, this video is really designed for medical professionals, so forgive me if I talk over your head. So today what we want to talk about is pneumonia, and what we want to really talk about are the various organisms that we're going to find causing pneumonia and how to best treat pneumonia in children. So in pediatrics, the bugs that cause pneumonia really shift over time. In the immediate neonatal period, the most common cause of pneumonia is going to be group B strep, and this will show up with group B strep sepsis. Usually these are children under 30 days of age with fever without source. They get rapidly ill very quickly. In a newborn with pneumonia, my recommendation is to intubate and send a culture. You can extubate immediately afterwards if you don't need to be mechanically ventilated, but it is a good recommendation that if you have a source, that source in a neonate, that source should be cultured, and you want to make sure you're treating the right thing because these children are fragile and they get very sick very quickly. Group B strep can be treated and is usually treated with a combination of ampicillin and gentamicin. And you say, well, gee, why are we using gentamicin to treat strep, since gentamicin treats mostly gram-negatives? And the answer is because when combined with ampicillin, it's actually synergistic, and the combination of therapy is better than using either one alone. People say, well, why use ampicillin and gentamicin? Because of the risks of renal toxicity from the gentamicin or ototoxicity from the gentamicin. And the answer is this. To date, all of the randomized studies looking at the use of broad-spectrum cephalosporins in sepsis in the neonate showed decreased survivability when treated with broad-spectrum cephalosporins. Most of those cases of death appear to be from yeast. And by using a broad-spectrum cephalosporin, you suppress the immune system, you alter the normal flora of the newborn, resulting in fatal candidal infections or Torreolopsis infections. So we can avoid that by sticking with the narrower spectrum older drugs. We're certainly hoping that a rapid test for connexin 1 gene alterations will become available so you can determine who is not a good candidate for gentamicin. But to date, such a test is not readily available. So that's the neonate and the most common cause there. As the children get to be a little bit older, so between roughly 2 months of age and school age, so roughly 4 years of age, the number one cause of pneumonia in a child of that age is pneumococcus. If it is bacterial, most of these pneumonias realistically are viral, and depending on who is reading your x-rays, a lot of the so-called pneumonias that you're seeing are really atelectasis from either bronchiolitis or atelectasis from asthma. And they're not true consolidative processes. And it's outside of the scope of this discussion how to read a chest x-ray on a child to rule out pneumonia versus atelectasis. But suffice it to say, if it's not being read by a pediatric radiologist, there's a good chance that a lot of your so-called pneumonias aren't and are really atelectatic processes. The other thing I see called as pneumonia from time to time is peribronchiolar cuffing or perihilar lymph nodes, again very common with bronchiolitis. And I've seen 1 or 2 thymuses in these young children diagnosed as pneumonias, and people wonder why you can't get that infiltrate to clear up, and it's because it's a solid organ sitting in front of the heart that belongs there. Please leave it alone. So the first thing I think, if you have a kid diagnosed with pneumonia under about 6 years of age, the first question you really have to ask yourself is, what are the chances this really is pneumonia? If you believe it's pneumonia, or if you don't have an ability to have that really ruled out by a reliable radiologist, then you need to treat. Strep Pneumo is your number one organism at this point in time, assuming that the child is not immune compromised. If the child is immune compromised, all bets are off. That discussion is outside of the scope of this discussion. If the child has a tracheostomy or has cystic fibrosis, that's really outside of this discussion as well. Okay, we're sticking with otherwise healthy, normal children coming into your urgent care or your family practice office. How do we treat strep pneumo? Beta-lactams. Specifically, amoxicillin is still the drug of choice. Because of the risk of intermediate resistant Streptococcus pneumoniae, we're recommending 80 to 100 milligrams per kilogram per day of amoxicillin. I personally divide it TID 3 times a day. I know that BID dosing, twice a day dosing, is very popular for amoxicillin. There are some really good articles showing the safety and efficacy of that in treating group A streptococcal infections of the throat, but to date I've not been able to find anything good. And just, today's date, it's March 24th, 2011. So 10 years from now, I could be speaking a different tune regarding this issue. But to date, I've not found any really good articles really demonstrating safety and efficacy of BID dosing for amoxicillin for strep pneumo infections in the lung. Because of the potential fatality for that, I recommend TID dosing at this point in time. And again, 80 to 100 per kilo of amoxicillin. If the patient fails that, then we may need to look at a broad-spectrum cephalosporin like cefdinir or Vantin, cefpodoxime. But at this point in time, I think that amoxicillin is probably the way to go. You do have a certain amount of treatment success with macrolides, but you have a roughly 15% treatment failure with macrolides. So I strongly recommend avoiding azithromycin and clarithromycin in this age group unless they're allergic to both amoxicillin and cephalosporin, third generation cephalosporins. I don't think it's in the patient's best interest. I know it's very popular in a lot of urgent cares to use azithromycin for these cases, but the treatment failure rate is very high. As the children get to be greater than school age, then what becomes really common, you still see a certain amount of strep pneumonia, and that really complicates issues because about a third of your bacterial infections are going to be strep pneumonia, and the other between half and third, or between 2/3 and between 1/3 and 2/3 will be Mycoplasma pneumoniae and or Chlamydia pneumoniae or Chlamydioides pneumoniae or Chlamydioides hominis infections. Or the rare psittacosis psittaci infections. That makes for a very complicated issue. If the chest x-ray is showing lobar consolidation, that's still strep pneumoniae, and as such should be treated as such. If the chest x-ray is normal, or if the chest x-ray is showing diffuse infiltrates, then that's going to be one of the atypicals. The Chlamydioides, psittacosis, mycoplasma. And that being the case, macrolides are the drug of choice. Because these Chlamydioides and mycoplasma bacteria do not have cell walls, beta-lactams, which destroy cell walls, are worthless on them, so you have to use something else, and that's where a macrolide comes in, and these are the drugs of choice for young children. As the children get to be a little bit older, you can also use doxycycline, but remember, in young children, you can't use doxycycline because of risk of damage to the teeth and bones. Neither of these infections are going to respond particularly well to your fluoroquinolones. So this is just not really a good choice for children. And there's some risk with fluoroquinolones. Now, for some of you who are hearing this who don't know me or haven't done a lot of pediatrics, you're saying, wait a minute, fluoroquinolones, you can give fluoroquinolones to kids. You absolutely can, and Cipro is in fact approved for use in children, but it's something that we really want to reserve for Pseudomonas infections in particular, or children with multiple drug resistant, or organisms that are multiple drug resistance where we don't have a whole lot of choices. So there really isn't much of a role for that in pneumonia of, again, normal children. We're not talking about cystic fibrosis patients here. You do need to be careful with the mycoplasma. 5-day course of azithromycin, 10-day course of clarithromycin will cure probably 90% of mycoplasmal infections. But there are 5 to 10% who do not clear with that, and those children can be very difficult to treat. If you think you're dealing with a mycoplasma infection and it's not responded to a short course of antibiotics, then the next step is to go back and get titers and follow the titers with a long course of antibiotics. Every year we have 1 or 2 treatment failures, and when we draw titers, we see that the titers are still markedly elevated, and with very long antibiotic regimens, the titers will eventually fall down into the normal range or back to 0. But again, giving these children amoxicillin or amoxicillin plus clavulanic acid is not going to fix the problem. And again, this is something I see coming from a lot of our urgent cares. Well, Johnny's been coughing for a long time, Johnny's really sick, so we're going to use a broad spectrum antibiotic. Choose your antibiotic based off of the bug that's growing or that is suspected to be growing in the body cavity that is infected, not off of how sick a patient is. And Augmentin is an inappropriate choice for both mycoplasma and realistically for most Strep pneumoniae, because if it's going to respond to a beta-lactam, it doesn't need the clavulanate. Mycoplasma will never respond to amoxicillin or Augmentin, and Strep pneumo is not a beta-lactamase producer, so adding clavulanic acid is not going to help. And I think we're going to kind of leave it there. There are some other unusual organisms. Children definitely can get Legionella, so something to always keep in the back of your mind, especially if you have a child who's been, exposed or been staying somewhere where there's a lot of air conditioning running. Children definitely can have gram-negative organisms growing in their lungs. Young children in particular can have undiagnosed tracheoesophageal fistulas that set them up for all sorts of aspiration-like pneumonias. And consequently, what you're treating what you think is a strep pneumo, but it's really an aspiration pneumonia from a small TEF that's not been diagnosed, especially if the child's 2, 3, 4 months old. Children can have undiagnosed cystic fibrosis, that being the case. Gram-negative organisms, Pseudomonas, growing is always a risk. Just because a child has been sweated once and has been normal does not mean that they don't have cystic fibrosis, and there's a good chance nobody's ever looked. If you're dealing with a child with multiple pneumonias, please, please, please sweat that child. And a single sweat chloride does not rule out cystic fibrosis. And children can have HIV, children can have cancers growing in their lungs that shouldn't be there, that are being misdiagnosed as pneumonias from chest x-ray. Children can be immune suppressed for any number of reasons that we have not yet diagnosed, including chronic granulomatous disease, that being the case Staph aureus infection, something you need to worry about. But in otherwise healthy children with no other medical problems, these are probably the big things to think about. So I hope this has been enlightening for you and helped to answer some questions, maybe to raise some new questions. And if we're seeing a lot of response to this and a lot of questions coming up, we can maybe do some follow-up discussions on Pseudomonas infections or infections in cystic fibrosis or infections in children who are immune compromised. If you are somebody who likes doing BID dosing for amoxicillin for strep pneumonia infections, if you've got some good literature, I'd love to see what you're reading. But if it's not coming from peer-reviewed literature, I'm actually not interested in seeing what you're reading, because if it's not been peer-reviewed, it really isn't worth basing treatment decisions on. This is Dr. Kevin Windisch. We'll see you next time.